Good morning. Thank you very much for joining us for this fifth seminar on oropharyngeal dysphagia in our INTENT series, International Teaching for ENT Surgeons. Just to remind you of the course overview, we have 6 topics presented through 6 webinars. This is our 5th and penultimate one. The first part of the webinar is about half-hour long and explains the patient journey of a patient in the UK with the topic pathology. And part 2 is a half-hour discussion forum with our expert panelists around the pathology of the webinar. The final part happens after the webinar at home. There's a reflective and evaluation form online, and on completion of the form, we will deliver your certificates. The certificates for sessions 1 to 3 have all been delivered, and sorry, there's a little bit of delay finalizing the session 4 certificates, but those will be with you soon. So remember to write your questions in the chat, and we will get to them in part 2. So without further ado, it gives me great pleasure to introduce our expert panelists, Ms. Sawant, Ms. Khwaja, Ms. Durant, on the topic of oropharyngeal dysphagia. Thank you very much. Just muted there, Rupali. Yeah. Try again.
Hello, I'm Rupali Sawant, ENT registrar from UK. I'm going to speak about oropharyngeal dysphagia briefly and post-operative oropharyngeal dysphagia. So this is what I'm going to cover in my presentation. Brief introduction of oropharyngeal dysphagia, swallowing mechanism, and post-operative oropharyngeal dysphagia assessment using ENT form. So a bit of background. Swallowing is a complex mechanism. It is a coordinated mechanism involving oropharyngeal, laryngeal, and esophageal musculature. Oropharyngeal dysphagia is the dysphagia which is difficulty in swallowing due to abnormality or abnormal function of oropharyngeal region. About prevalence of dysphagia, many studies have quoted different numbers. In general population, it is quoted that almost 15 to 16% patients present with dysphagia. In hospitalized population, stroke patients present with 51% patients present with dysphagia, and neurodegenerative diseases dysphagia is also common. Almost 48% patients present with dysphagia. And head and neck, following that, head and neck cancer patients, 34% patients present with dysphagia. How it affects the health? Because of dysphagia, the lack of nutrition and recurrent respiratory infections, aspirations causes more comorbidity. So how normal swallowing happens? These are the phases of normal swallowing. Oral phase, oral preparatory phase happens in the mouth. And when the bolus is pushed to the oropharyngeal region, the soft palate closes nasopharynx. And as the bolus is pushed further, epiglottis closes the larynx, and bolus passes to esophagus. So all these movements need a lot of coordination. And in each phase, like oral phase is mainly controlled by voluntary muscles, pharyngeal phase is mainly reflex phase by brainstem autonomous nervous system, and esophageal is peristalsis. So this is just a list of causes of oropharyngeal dysphagia. Ms. Khwaja is going to talk about it in detail. Then how each subset affects dysphagia is if there is oral dysfunction, if there is abnormality of tongue base or pharyngeal sensation or musculature, vocal cord function, and again function of musculature which causes failure of laryngeal elevation. And any one condition can affect all these or any of these subsides. For example, stroke can affect all of these. So about assessment of patient, history is a key. We talk about onset, duration, and progress, as well as associated symptoms of dysphagia. And we have to rule out malignancy in every patient. Examination is concerned is structural abnormality as well as functional abnormality, and having assessment done by flexible nasal endoscopy, as well as assessing overall patient's health. Investigations that is for further assessment of swallowing of patient. So video fluoroscopy gives us some dynamic assessment. Barium swallow gives us structural problems or any dysmotility. Again, FEES, TNO, CT, MRI, they are cross-sectional imaging, mainly very useful in cases of cancer patients. Again, Ms. Khwaja is going to talk about it in detail. So this is just a brief differential diagnosis depending on onset of dysphagia. If there is any acute onset, then we have to suspect foreign body trauma and emergency management is required. A shorter duration and progressive symptoms, then we suspect malignancy and cross-sectional imaging is required. If there is a gradual onset and dysphagia is more to liquids than solids, we suspect achalasia and barium swallow is useful. Again, gradual onset, but associated symptoms like regurgitation, respiratory infections, then we suspect pharyngeal pouch and barium swallow again is useful. Gradual onset and associated other symptoms like neurological deficits, neurological weaknesses, then FEES and video fluoroscopy, CT scan is useful. Now, this is about a postoperative oropharyngeal dysphagia. So, during general anesthesia, especially prolonged general anesthesia, affects this phase, oropharyngeal phase of swallowing, as general anesthesia overall suppresses the reflexes of throat, and that can lead to less sensation in that region as well as aspiration. And immediately post-operative period, patients do suffer from dysphagia, which gets missed, and that could lead to further complications, inadequate nutrition, delayed wound healing, and aspiration, and because of aspiration, respiratory infections that could lead to further complications and increased hospital stay. So the patients who are at risk of developing this post-operative dysphagia, the patients who have reduced functional reserve for swallowing, and the patients who have comorbidities related to neurological comorbidities, respiratory or cardiac comorbidities. So we did a pilot study using a eating assessment tool to assess the preoperative swallowing and postoperative swallowing of such patients, and if they had any postoperative speech and language therapy input. So this is this form, which is E10 form, which is a validated tool. It has got 10 questions, and each question is scored from 0 to 4. And the score of 3 or more is significant, and it suspect dysphagia in that patient, even if the patient themselves, they don't complain about it. So it is good to have kind of this assessment, and we like have a watchful kind of watch these patients during perioperative period if they need any speech and language therapy input as early as possible. So this was the conclusion of that study. So the patients who had higher score preoperatively, they also had postoperative higher score, and they did need speech and language therapy input in postoperative period. And those were the patients with the comorbidities which I mentioned earlier, and elderly patients. So this is a useful tool, and patients themselves can also assess, or any such high-risk patients, we can assess them preoperatively and keep an eye on them. So that's me. Thank you. I'll stop sharing.
Hi, Orlin. Do you want us to go next? Yeah, super. I'll just share. Not that one. Yeah, it's already on there. Somehow we're just looking for our files at the moment. I just wonder if it's just open too many of these.
Should we share and then pull that up?
Yeah, I should do, but I think we need to find it. But it won't be on there. It needs to be bringing up here. Sorry, Ireland. I think it's just we're not finding our files at the moment.
No worries.
Not being brought up.
We tried it earlier though. Is it disappeared?
Yeah, it's just disappeared off the screen. Don't know why.
Okay, no worries.
Oh. I think
This one, thanks for a great talk. All of those tuned in from Mongolia, please do please do put your questions in the chat so that we can discuss them in the forum part of the seminar after the second talk.
Can I?
Yeah, go ahead.
It looks like Mr. Loughran may not be joining.
No problem, that's no worries. Great, Sadie, and so we can see your slides. So if you enter full screen, you're good to go.
Okay, guys, nice to, I was going to say nice to meet you, but obviously I'm not seeing you, but it's our first visit to Mongolia.
Yeah.
All right. So my name is Miss Sadie Carter. I'm an ear, nose and throat consultant. I'm based in Manchester, and I, with a lot of my co-colleagues, look after dysphagia, and so I'm introducing Sue.
Hi, I'm Sue Durant. I'm a speech and language therapist, and I work with Sadie. My sort of specialism is within head and neck, so I deal largely with patients with head and neck cancers and subsequent dysphagias.
So Rapali asked us to talk about dysphagia from a benign setting. So what we'll go through is really just breaking it down, what dysphagia is, what do we see in our clinics, how do we manage them, and where the challenges are. So, oops. Is it playing up? There you are. Oh, right, so this video is not working at the moment, but we're going to flick to the next one, and you're just going to talk about.
Yeah, so I'll just run through this really briefly, because obviously Rupali's given us a really nice description of the normal swallow, but just to say, really, it's broken into these main 3 phases. So the oral phase, chewing up food, moving it around the oral cavity, being able to propel it towards the back, and then the trigger of the pharyngeal phase, which is reflexive, closing off your airway, squeezing the bolus through the pharynx and into the esophagus, and then the esophageal phase. And just to say, really, that it is a really complex mechanism. It requires coordination between respiratory system, gastro system, and all of the laryngeal and pharyngeal and oral musculature all working in a really finely tuned way in order for it to work really well, to be able to get that nutrition, the hydration safely, and protect your airway at the same time.
And I think I was going to say, the other thing is it's involuntary. That makes it that you don't think about your swallow. It's just, we put something in our mouth and we just assume it'll get to our gullet. And I think, like most things, it does 99% of the time. And it's when it doesn't work that it becomes the problem. Yeah.
So just to kind of clarify really what dysphagia is. So to use that term we use for any problem that's to do with chewing up, manipulating food in your mouth, and then being able to swallow it. And we kind of refer to that, any difficulty with normal diet, normal fluid, being able to follow that process, we would describe as a dysphagia. You can see there one of the main things that we're always looking out for, which is aspiration, which then affects the respiratory system in the lungs and can lead to infections, particularly in the lower right base.
But prevalence, I mean, it's I'm talking about European or a kind of Western society population. So 16% is quite a high. I mean, that's literally just short of 1 in 5 people. But it gets even higher if you're actually in hospital. I mean, in the general kind of admissions, it's around about 19%. We'll assume that most of this is a slightly older population. But the main kind of factors, 50% of stroke patients will have problems with their swallow. In the world we live in, which is head and neck, where at least 1/3 of them will have a problem. And then even higher is that neurodegenerative diseases, and those cross all boundaries. And you're again talking about just short of 50%. So the disease burden of dysphagia is quite significant. And if I kind of teach students, I always talk about dysphagia because it underlies a lot of our health. And really the impact on health, as Sue's going to mention, is quite significant.
Yeah. So on the right here, you can see the main issues. So we've got, obviously, it can lead to a lack of adequate nutrition and hydration, but obviously the implications of that, particularly for poorly people, which is where we often see dysphagia the most, is that then that in itself has an enormous impact on their rehabilitation from whatever illness it is that they're struggling with. And if they've had surgery, that can then obviously affect their healing from that surgery. So it's that kind of roundabout effect that it has as well. One of the big things that we're always looking at is the impact on the respiratory system. So largely related to recurrent lower respiratory tract infections, or more acute, severe infections like pneumonias, leading to respiratory failures. I think it's probably worth mentioning at this point as well that there's often a talk about the risk of aspiration and the risk of aspiration with dysphagia. I think it is really important to kind of consider all this as a bigger discussion, but largely it's the risk of pneumonias. A lot of people who aspirate won't actually develop a pneumonia, but it's those people where there are other underlying medical conditions, which are often people that we see in hospital, that are at a greater risk if and when they aspirate for developing a pneumonia.
All right, and as Rupali mentioned, I mean, dysphagia, to think about it, is really to divide it into onset. And an acute onset in all of us who do ENT really breaks down into trauma and infective and inflammatory. So the picture on the left, guess what? It's a safety clip. in a little child, and this only came in a couple of weeks ago. So, you know, foreign bodies, I think in all of my 20 years, I've seen literally anything and everything in the aerodigestive tract. So always think about foreign bodies, or particularly, again, caustic burns or any toxic burns, self-inflicted or not, usually will cause an acute onset of edema and swelling, and unfortunately longer term problems, possibly of strictures. On the other side, infective inflammatory, there is a whole gamut of infection and inflammation throughout the aerodigestive tract, again, from the pharynx to the supraglottis. Also in the neck, neck abscesses will compound on the esophagus as well and give dysphagia symptoms. Reflux symptoms, significant reflux, can come back as supraglottitis. And even though it's not directly in our remit as ENT, do always think about eosinophilic esophagitis. I've seen so many children who come in with foreign bodies, who you remove the foreign body and there's edema there, and they come back with a recurrent history. So as for my gastro colleagues talking about this subject matter, they're actually quite keen, if we're taking foreign bodies out, to do a biopsy at the same time, because I think the degree of eosinophilic esophagitis is underreported, and they're really quite keen to try and get on top of managing those patients early, if possible. Coming to dysphagia clinic, so I run a clinic once a week looking at dysphagia, and this is all sorts of dysphagia. So the clinic itself, I think it really breaks down into every kind of condition. You can see this is quite a heavy slide. The reason being is there's, when we talk about dysphagia, it's a neural and muscular mechanism. And so neural problems, muscular problems, and overdriven by the brain itself, there is 101 pathologies we can think about. But to divide it up, I would really work through these kind of sieve. And so you can start with congenital. So cleft or congenital problems will give you some elements of aspiration and chest infections, usually picked up by our pediatric colleagues, and or respiratory pediatrics as well. Do keep in mind that pediatrics as well, if they have learning difficulties due to global development delays, they are at high risk of dysphagia symptoms due to aspiration, and that is just due to usually muscular hypotonia or other elements of the neurological condition itself. We have a really good relationship with our rheumatologists because, again, soft tissue disorders can have an impact on swallow, and that can range from scleroderma, SLE, Sjogren's, and dermatomyositis. So I wouldn't worry about the conditions. I usually just get my rheumatology colleagues to get involved, and they can help work up these patients. The commonest thing with any soft tissue disorder is how it heals, and that unfortunately is by fibrosis. And the problem with the gullet, it's a soft dynamic tube, and really it works on stretch. So as soon as you start tightening it up, it has impact. And in the case of autoimmune conditions, it's usually fibrotic tightening of that gullet. Neoplastic lesions, again, head and neck tumors, but on the benign side, vagal nerve tumors, they are rare. We see probably about 2 or 3 per year. Paragangliomas, and the problem is the devastating effect of taking out the vagal nerve. It's just hard work, isn't it, for you guys to look after these patients, because it's a full-on dense problem with their voice. Obviously I look after, but the swallow impact is huge. They do well though, I mean, because usually this is unilateral, and so they do have a compensatory mechanism kicking in. They're usually younger people, so hopefully there is reserve, but you have to really work with them. But most of the ones we've done actually have a swallow that they function with, isn't it?
Yeah, and I think it's difficult because if you've got kind of that complete vagal impairment, then you get both the sensory and the motor side. So you know, you're running into sort of silent aspirations and things like that. Then so that's where the instrumental assessments come in really helpful.
Yeah. Motility disorders do come under odds, but also gastro, particularly esophageal spasms. I see a lot of esophageal spasm in the clinic. A lot of it's driven by reflux kind of history. There is also a little bit related to age as well, and I'll cover that a little bit later. Webs are usually related to autoimmune conditions, and eclasia is again dealt with the gastro people, and usually it's hypertrophy of the lower esophageal sphincter. Neurological burden is huge. I think with an aging population, this must make up a lot of your work as dysphagic therapists. So anything from stroke to Parkinson's, MS, MND, myasthenia gravis. A vocal cord palsy is put in here, but unless it's a dense palsy or it's actually bilateral, palsies on themselves are not the main culprits when we come to dysphagia. Age-related, as we've already mentioned, can lead to pouch development, and general frailty obviously causes dysphagia as well. The other,
I was just going to say, I think that's probably
another big area.
It's a massive area, because just that natural degradation of the swallow, then anything else that happens acutely on top of that, any medical illness can then, it just means that people don't have that reserve, and that tips them over into being dysphagic. And
do they actually ever come back to their baseline, or do you find that it's just a slow?
Some do, and it will depend how long the acute illness is lasting, what nutrition you get in, and what else is underlying. So if they've got sort of cognitive deficits or some level of dementia, then you'll often find that they don't come back up fully to baseline, but it's a gradual sort of decline.
Absolutely. And they do make up a lot of my clinic, the iatrogenics, whether that is post-radiation treatment for head and neck cancer, head and neck surgery itself, or as we've mentioned, vagal nerve palsies or recurrent laryngeal nerve palsies. And I have to say, this kind of group generally don't have significant dysphagia, but they do have voice problems. But they can be anybody from the lung malignancy to the thoracics, or even the vagal nerves are usually cervical surgery or the carotid endarterectomies as well. So there's a huge range of people in the neck that we need to think about when it comes to iatrogenic injuries. And then finally, respiratory. How do you feel COPD?
Yeah, so again, I think respiratory is another large kind of area of our caseload within the acute hospital setting. And essentially, because you've got that fine balance between swallow mechanism and respiratory system, when you've got some level of compromise like you would see in COPD, your body essentially is going to prioritize breathing and gas exchange over closing off the airway for swallow. So that we often see that leads to sort of a delay in the pharyngeal section of the swallow, a delay in closure of the airway, and therefore less airway protection. And we often see silent aspirations, that aspiration that's happening without the patient having an overt cough response to that. So it's something that, again, we would have to use instrumental assessments, which we'll talk about in a moment.
Yeah, absolutely. So this is just the same slide, but just giving you a feeler of how many different specialties are involved with dysphagia. So it's not us ENT, it's the whole gamut of specialties, and we do form a community of specialists when we come to looking after dysphagia. Rupali has mentioned this, but just to get the key points on taking that history, as you've now recognized, age plays a huge part in that dysphagia symptoms, whether it's actually onset, that age dictates what the likely pathologies are, or what the rehabilitation element will be likely success of the rehabilitation. Onset, as we've described already, the morbidities, as we've also already mentioned, and neurological conditions. The other little bits of that history, as mentioned, is really the kind of sticking, coughing, choking, regurgitation, because they kind of help to lead down what particular pathology is causing dysphagia. But I really like the severity and the impact. Really tells me how quickly I need to do something about the dysphagia. Significant weight loss obviously can sound sinister, but also can basically show progression of the disease process itself, associated with respiratory symptoms and the choking. We all know the red flag symptoms, so we always do need to keep that in the back of our heads just to make sure we're not dealing with a malignant pathology. We've already mentioned the E10 score. I do love it. I find it very useful to pick up pre-morbid dysphagia. So that's dysphagia that's happening that isn't recognized by the patient because it's very subtle, but has impact. And what happens, I think, like we're all human, we modify straight away. Oh, if we choke on something, we'll say next time, I'm not going to have that, or I'm going to make that food a little bit more softer so I don't have to change. So we change our habits before we actually come and ask for help. And there is the problem with dysphagia, because it's always there in the background long before the patient presents with the problem. And that is itself a little detrimental, because we can only bring you back to the baseline that you present with. We can't necessarily reverse unless you're young and you can have some reserve already, but generally we're only kind of bringing you back to where you presented. So this is a busy slide about assessment, because there's a lot of assessment in dysphagia. So we will run through this. Basically, there's structure and there's dynamics. On the structure side, plain X-ray is useful really in the acute setting to look at, is there a large object that's obstructing the airway, or is there any kind of foreign body there? CT and MR is really reserved for ruling out malignancies and growths, as already described. Where do you think bedside assessment sits?
Yeah, so we call it a bedside assessment in speech and language therapy, but it's essentially our kind of the bread and butter of our assessment of the patient. So in combination with the case history and the patient's description of what's happening with their swallow, we'll use oromotor and cranial nerve assessments. We'll give the patient oral trials of different fluid and diet consistencies. And with those oral trials, we will use tools like cervical auscultation, palpation of the thyroid and tongue-based movement, and then observation of any overt or silent signs of aspiration to give us an indication about what we think is going on and what is safe and unsafe for that patient. Often I've kind of touched on the idea that there is silent aspiration. So that's when the patient doesn't have a natural cough reflex when material is entering into the larynx or below the level of the vocal folds. That's when our instrumental assessments become really, really helpful. So we've got our main two are nasendoscopy, so use of nasendoscopy to actually visualize. It's really, really helpful to assess the structures, the movement of the vocal folds, the anatomy and physiology of the larynx and pharynx, and we can also use oral trials with that. It's really nice and mobile, so that's something that we would use on a ward setting or in outpatients, and we can also use that to assess sort of secretion management, so that's really helpful.
Yeah, and so within those flexible image scopes, we have TNO, which is transnasal esophagoscope. I sit in a clinic, and what the role of that, the TNO, is really diagnostic, so biopsying lesions as I see them. It's also to do procedures, and so procedures in my kind of field will be dilatations of the strictures if we have them. It's also to assess the gullet function itself, but the TNO is really revolutionary for us because it helps us do an assessment as well as a procedure in a clinic setting. So, patients are, not needing a general anesthetic. They have some local anesthetic to do the procedures in. These are generally very accessible clinic setting things, but there is obviously imaging and in the form of video fluoroscopy. Where do you think video fluoroscopy sits, shall we say?
Yeah, so again, it's really helpful to assess structure. So this is a moving X-ray, a fluoroscopy X-ray. It's also described as a modified variant swallow because we will use additional sort of frames per second, so we get a really, really good image of what's happening at an oropharyngeal level. It helps us to understand physiologically what's happening, but whereas FEES is really helpful for secretion management, movement of the vocal folds, whereas video fluoroscopy will help us to understand volume of aspiration, a patient response to that aspiration. If they're coughing, are they managing to cough all of that back? Because we can see CP level, below CP level, below vocal folds. And we can also trial different sorts of strategies, postures, and see if those things are helpful in minimizing aspiration or helping them to couple back.
Yeah, and within that, bear and swallow is very similar to videofluoroscopy, but it's much simpler. It's not done with the speech therapist being present, and the image slices are less, so the quality isn't as detailed as the videofluoroscopy, particularly in the pharyngeal phase. So it really just gives you a good, really good actually picture of the gullet, the whole swallow. I mean, because I know we deal with the first stage of the kind of oral pharyngeal and the top end of the gullet, but you know, swallowing is all the way down, so one does have to learn about what's going on in the gullet itself, and the bear and swallow is a really good overall picture all the way down into the stomach itself. It will pick up, as we mentioned before, tumors, webs, strictures. It will pick up dysmotility. And I think dysmotility is one of those words which is slightly abused, partly because I think dysmotility does exist as we age. And so what is normal or acceptable dysmotility versus abnormality is a kind of a discussion point at the moment in the world of gastro. And I think we will just have to wait and see when do we have to kind of move in and deal with dysmotility. Patients will present with the symptoms of that dysmotility and food sticking, but how much is it abnormal and normal, I'm not so sure. Similarly, other kind of assessment tools are GLPH and pressure manometry. I do have access to this and do use it. I particularly like this where you've got a challenging patient where structurally everything looks fine on a bear and swallow, but they're still symptomatic, and it's particularly related to motility, that you want to know a bit more detail about the upper esophageal sphincter and the lower and how they work together. And that's how does that bolus move along in that pathway. And the detail you get is phenomenal. You really need to be interpreting that with a gastrophysiologist. So it's within our remit, but you do need to have an understanding of the kind of the investigation itself.
Just about 2 minutes left there.
Yeah, we're nearly through the bulk of it. So these are just picture images now showing you what a bear and swallow looks like, as it says, delineating the gullet as it works down the pathway. Videofluoroscopy similar?
Yeah, so just a couple of still images to give you an idea of how it's helpful to assess structure. So we can see there a large osteophyte in the pharynx, which has potential to cause functional impact on epiglottic retroflexion and passage of the bolus. And then on the right, you can see a reasonable amount of aspiration there into the airway.
Yeah,
which has gone below the level of the vocal folds.
Absolutely. Similar fees?
Yeah, so with fees, again, helpful to assess structure and function of the vocal folds. You can see there a vocal fold palsy on the left picture. And then on the right-hand side, it just gives an indication of how helpful it is to assess secretions, which is something that we wouldn't be able to see on a videofluoroscopy. So you can see there secretions sort of pooling in the vallecula down into piriforms and actually overspilling a little bit into the airway. So that's something that we would then want to manage those secretions before we potentially move on to oral trials.
And here's just a pictogram of a patient having a TNO procedure done. As you can see, sitting comfortably in the clinic. This is COVID land, and this is a balloon, and now we're feeding the balloon down. You can just see the balloon being passed in, and you could probably just see on the screen the balloon sitting in position, being ready to be dilated. This is a picture you get with a GLPH and pressure manometry, and you're looking at the pathway of the pressure as the bolus is transiting through the esophagus itself. It has phenomenal amount of detail here and really, really useful, as I mentioned. So just to cover finally, pharyngeal pouches, it is our bread and butter in ENT, and they come in all sorts of different sizes and shapes, and bear and swallow is our key kind of investigation tool. And as you already know, it kind of presents with a regurgitation history. But can I just take you one step back and just talk about disease progression? And pouches at the end here, being a large pouch, started life as a cricopharyngeal spasm. Over time, it would become hypertrophied. over time, it would have caused a small pouch, which with stretch becomes medium and large. And the treatment pathways, and this is the kind of my treatment pathway for patients who present to me, is absolutely dependent on which one of these they present with. But they are a spectrum of the same condition. So in early spasm, I will balloon dilate, as you've just seen in the clinic. If it's a hypertrophy, I would take them to theatre and place a Botox injection, about 100 units, into the cricopharyngeus. If it's a persistent hypertrophy, then we can consider myotomy, either as an open or endoscopic procedure. And then pouches, basically, it all depends on the size of the pouch and the challenging anatomy of the patient. So if the limitations are of the difficulty in flexion of the neck, you may end up having to go to open. If it's a flexible neck and a medium to large pouch, stapling is a good choice. You might do a combination. So I would generally do, for medium to large, is a stapling with a laser. My preference now is a blue laser, and I've moved on to that because the blue laser is available on a flexible fiber, and it allows me just much more access and ability to take that pharyngeal bar down as far as I'm comfortable. And we end on basically the 3 messages about rehabilitation management.
Yeah, so I'm aware we're short on time, so I will run through this like a whistle-stop tour. Essentially, we're looking at, from a speech and language therapy perspective, preventing aspiration, optimizing hydration and nutrition. So to prevent aspiration, we might look at texture and fluid modifications to make that aspiration less likely. Where that's not possible, we might look at alternative routes of feeding, either to fully feed a patient or to supplement. So that includes NG tubes, rigs, pegs, TPN, total parenteral nutrition. Obviously, we have a large role in rehabilitation, so that's therapy for strengthening the oral musculature, improving sensation, improving cough clearance of any aspirated materials, looking at sort of postures, maneuvers, strategies that help to reduce aspiration, and then there are the surgical inputs.
Yeah, and is this the Phagenics? Is that?
That's Phagenics.
Yeah, so Phagenics, just to say, is a device invented actually in Manchester, and it is used mainly on the stroke, I think, patients.
Yeah, and on critical care. There's most researchers in stroke, but they are moving it out, and it's essentially for patients with a sensory impairment that's impacting on their swallow function. So it aims to stimulate the pharyngeal mucosa. We don't really understand how it works, but it does
seem to help. Yeah, help in the rehabilitation, especially those patients who have been in intensive care or have a long period of time where their swallow mechanism hasn't been working. Now we swallow all the time, obviously, because we're swallowing our saliva, but the actual physical action of swallowing and the way we're using the muscles quite aggressive, or not aggressively, but in kind of sequence. If that's out of action, and I think even just for a couple of days, even it actually has its effect. So imagine ICU patients where their swallow is out of action for weeks on end, or could be even months. So I think that this definitely has a role in that re-stimulation of those sensory endings that will help recovery or rehabilitation faster. So super, I'm hoping that was a whistle-stop tour through dysphagia on the benign side, and we're open to questions, I think.
That was brilliant. Thank you very much. Gan, have you got any questions from the audience at all?
None by now.
Okay, no worries. So I'd like to ask you, what kinds of differences in practice have you noticed listening to that talk between the UK and Mongolia?
Actually, I don't notice any difference between the UK and Mongolia, because nothing to compare, because the entire discipline of this swallowing issue in ENT field is kind of just an initiating stage in Mongolia. So that's why I just recommend all of you that would like us to let us know about some swallowing and issue. But yeah,
Okay, great.
yeah,
So this is a field that's just starting in Mongolia.
yes, yes. About the speech pathologists, we also now, you know, they refer the patient to the speech pathologist unless there's just post-op CI, you know, post-CI issues, and unless there's nothing to, you know, and no one goes to just the speech pathologist by now. So among the Mongolia, there's at least, I think, 3 to 5 speech pathologists for the entire country. So that's the just the
Very rare too.
yeah. That sounds crazy.
Yeah, and when I came to visit you, Gan, a couple of years ago, that was the situation. There were so few speech therapists. Is there any increase in training pathways
Yes.
or anything? I
As
imagine COVID set you back as well.
As I remember, the publishment that called through it with you is noted that it was like 1 to 2 speech pathologists, I think. Now it's like 3 to 5.
Okay, okay. Fine. Any questions that you have on the chat at all?
None by now.
Do you want to make a quick announcement in Mongolian, maybe?
Одоо вебинарт оролцож байгаа оролцогч нарт дундаас одоо энэ спикерүүдээс асуух асуулт байна уу? Яг тэгэхээр энэ дисфаги гэдэг сэдв маань өөрөө зөвхөн залгилтын нэг нэр төдийн юм биш, маш олон юмгийн дундаас үүсч болдог том хам шинжийн зөвөрөгчөөс үүнтэй холбоотой асуух асуулт та бүхэнд маш их байгаа гэж бодож байна. Тэгээд хамгийн гол нь энэ дисфаги гэдэг зөвөрийг чихамар хоолны амьд оншиж цааш нь дамжуулж ялгаж ялгаа онцлогоо хийж өгөх шаардлагатай байдаг учраас энэ сэдвийг албаар энэ 6 дараалсан вебинарын 5 дахь сэдв болгож оруулсан байгаамаа. За та бүхэнд асуух асуулт байвал чат хэсэгт ямар нэгэн эргэлзэж санаа зовох зүйлгээр шууд кириллээр монголоор асууж болно. Би цааш нь англиар дамжуулж орчуулж болно.
Brilliant, thank you. So at the moment, if someone presents to your clinics with oropharyngeal dysphagia, what would you do for them? Would you do some of the investigations that we have, such as barium swallows, nasal endoscopes, and so on?
Most of the as far as I know, in my experience, I've encountered with 2 cases who's suffering the dysphagia due to the stroke, I think. But yeah, you know, the patient is unconscious, so there's no chance to identify there's some swallowing issues, but they're feeding the nasogastric tube, but it was hard to you know, identify it. But the last 1 year I participated since September. It was the American Academy of Otorhinolaryngology. It was some concept that some of the section of this entire lecture is providing some swallowing issue. That's the section that I just, you know, just the inspiring issue that it's just pick some ideas to start initiating some swallowing beginning in Mongolia. So
I think again, just a couple of the points that we raised. I think using the E10, as I said, is a really great tool. You know, it's helpful just to use that as a guide. And then I think, you know, training, obviously speech therapists, if there's only 3 of you in the country, so it's limited.
Yeah, in our possibility, just a capability, so we can easily do the barium swallowing and also the FEES. So there's, yeah, so there's nothing to, you know, some conflicts or something difficulties can do that. So it's easy to also
I was just going to say, we're more than help. I mean, if you need training, I mean, these days everything is worldwide. We have a great unit here. I mean, super speech therapists, and they can do online learning and training as well for you guys if you've got an interested group of, you know, people who want to learn about speech therapy and learn the kind of skill sets that you need.
Yeah, that's really good to know, because the hospital that I just work currently is just the tertiary care hospital. The patient who is they're running out of some options, just go to all hospitals. So in that hospital, we really desperately need to that kind of section. So you know what I mean.
Mm.
Thank you, Ms. Khawaja. That's very generous, and that's the kind of opportunities
that was really generous.
the program is trying to foster. I think there's a question in Mongolian on the chat. Again, if you wouldn't mind translating for us.
I'm going to say my Mongolian is not quite up to it yet.
Mine neither.
The attendee is trying to ask that any experience that you're encountering, how you do fix the esophageal hernia. I think they're trying to imply that the esophageal diverticulum, I think. So if there's some esophageal hernia, how do you just handle this? That if you manage it, just properly, can that reduce some kind of GERD symptoms?
Sorry,
that's the question.
So are they saying about development of the pouch?
How do you handle some esophageal hernia?
Is it hiatus hernia they're talking about?
In the UK, hiatus hernia again is mainly treated by general surgeons.
Yes.
I'm
also some kind of, I feel some hazy because
so I don't know if our panelists have any comments, but that's mainly as far as I understand, GI surgeon.
Yeah, hernias are very common. I think again, it's a disease that comes with partly, I think, as we live longer, I think, and also the lifestyles that we lead. So I think hernias are, you look at enough barium swallows, you will pick up a hernia on the investigation. Do we treat every hernia that we see? No, we don't. We treat the symptoms, and that usually involves at least a trial of a PPI and a gastroscopy to assess the mucosa, to rule out the things you want to worry about is when it becomes a hernia, where there's a risk of a Barrett's esophagus leading to a malignant change at some point somewhere down the line. So as a baseline, you would need a gastroscopy to do the assessment. And then you treat symptomatically the patient's symptoms. So most of this is dealt with medications, with reflux medications. Unless the degree of the reflux is significant, as in it's heartburn coming up to the throat, then you would go down that route that I've mentioned of a barium swallow, but also pH manometry, because that will then dictate also what degree of hernia it is. And then it's going on to the endoscopic upper GI surgeons who deal with either wraps or funduplication procedures. I have to say, from my personal experience, funduplication isn't for every single hernia patient. It does seem to be that the outcomes aren't as great as you would think they should be. So it's a very challenging area of picking the right patient, because unfortunately it's a one-way. Once you've done it, you've done it. So I think there's a limitations of that procedure. So you'll manage symptomatically, but you need to rule out obviously anything more sinister.
Yeah, I just add to that from my experience, they're incredibly selective about which hiatus hernias they repair, for sure. So again, would you mind announcing in Mongolian? We have our QR code for our reflective form.
Yeah. Sure. За өнөөдөр вебинарт оролцож байгаа оролцогч нар яг энэ QR кодыг яг одоо ашиглаад уншуулад survey form бүглээд дараа нь сертификат авч болно. Эсвэл би дараа нь нийгмийн групп, Facebook групп дээр тухайн формын линкийг бас тавиад дараагийн вебинар болох хугацаанд энэ survey-г бүглөөд юугаа авч болно. Сертификат авч болохоор байгаа шүү.
And just in the time that's left remaining, again, I wanted to ask oropharyngeal dysphagia, the treatment of these conditions, are there infancy in Mongolia? What are the next steps, concrete steps to establishing a service, and how might ENT UK be able to help you with that?
Yeah, actually the idea is already popped out of from I think. Yeah, I'm sorry, it's Sadi, I think. She already popped up the idea, so that's just the beginning. So because the gold standard identification the test is not hard to do that. So we need some specialists who can just do that. So that's the first step.
Yeah, I would say just that we can start with an online learning program, and then it's a case of kind of visiting, isn't it, to kind of get the kind of face-to-face learning at some point. But I mean, here in Manchester, we have a huge department related to dysphagia, and we're actually a training centre as well, aren't we? I mean, we actually train the speech therapists to do the FEES procedures. So you've already got the nase endoscope, obviously, because you do that in your clinic. So your next step would be to be just trained on what to look for when you do a FEES. And that can be trained, that's not a difficult thing. It comes down to experiences. The other thing I would open up as a resource is that where I work, we work as a team. And so FEES for us is day in, day out. I think they're on the wards all the time doing these procedures. But the video that they create then is saved onto our hard drives, and then I will work with them and we watch videos. I've spent half my life watching videos purely because it's a teaching tool as well as I give advice on them. And you're more than welcome to join one of our sessions, and you can be picking up knowledge of what we're diagnosing, what pathologies we're seeing, and how you can take that back. So it's just having that knowledge and resources available to you guys, and then obviously training, as we talked about.
We're in our last minute, and we have a last minute question. So a minute answer. What is the mean strategy of age-related dysphagia? I suspect what that means is, what is the general strategy, if you can have a general strategy with age-related dysphagia? Maybe one best for Sue.
Yeah, I mean, largely, if it's age-related, there's often something cognitive that's underpinning that, or again, other kind of comorbidities. So I think primarily, as speech and language therapists, we will always try to avoid modifying diet and fluids where we can. But I think when it's that kind of age-related, it does end up that we tend to end up modifying the diet and the fluids, looking for the safest consistencies. But I do think it's really important to consider that in a more holistic context around quality of life as well. So we won't just always go down the modification route. We would always look at that patient and involve them and the family in terms of what's best for them, balancing up, managing the risk of aspiration with the nutrition, but then also maintaining as much quality of life for the patient as possible.
Thank you so much for that answer, and thank you to all three of our panelists. Brilliant talks, very generous offer from the MRI. Thanks everyone. Fill out the form, and we will see you next week for our final seminar on pediatric airway management, which is sure to be a brilliant talk. So yes, thanks again to all our expert panelists. Please fill out the form. Thanks again.
Thank you. За оролцож байгаа хүмүүс бүгдээрээ энэ survey form-ыг бүгдээрээ нэгдүгээр 97 хоногт болохоор хамгийн сүүлийн вебинар болно. За тэгээд оролцсонд баярлалаа.
Bye now.